This rare footage of an actual malignant hyperthermia crisis was taken inadvertently while filming a lengthy oral surgical procedure. At 1 hour into the procedure, there was an acute rise in the skin temperature, reaching 37 degrees centigrade. An acute sinus tachycardia was noted, as well as an increase in CO2 production. The heart rate was 140 beats per minute, and the core temperature measured by an esophageal probe was 39 degrees centigrade, a 3-degree rise from her baseline. The heart rate continued at 140 beats per minute, and the core temperature rose to over 40 degrees centigrade. On the basis of the acute unexplained tachycardia, temperature rise, and increased CO2 production, the diagnosis of malignant hyperthermia was made. The procedure was discontinued, the anesthetic stopped, and the patient was ventilated with 100% oxygen. To control the rising temperature, total body cooling was initiated by placing the patient in an ice bath. Sodium bicarbonate was given intravenously to control the profound respiratory and metabolic acidemia. The surface cooling was effective for this patient, and the core temperature was decreased to 36 degrees centigrade. The successful treatment of this MH crisis was state-of-the-art therapy at the time this episode occurred. It was a time, however, in which the mortality rate for those stricken by MH approached 90%. Her pulse is up to 182. Her breathing is fast. Temperature 103 degrees and has been going up rapidly for the last couple of minutes. Blood pressure 156/95 and unstable. There is cyanotic mottling of the skin. She's sweating profusely, and there is marked rigidity of the extremities. It's malignant hyperthermia. The anesthesiologist calls for help and assigns tasks to members of the anesthesia team. He calls for dantrolene, iced saline, ice packs, and the establishment of an arterial line. Speed is one of the most important factors in MH treatment. Delays can result in a high percentage of fatalities, but immediate treatment with aggressive measures can reverse the process. The MH emergency cart plays a central role in this life-saving effort. It contains 36 vials of unexpired dantrolene sodium IV, sterile water, procainamide, sodium bicarbonate, and other drugs and equipment which are required for effective MH treatment. The MH operational plan is activated as soon as the diagnosis is made. These are some of the key points to remember in controlling the MH crisis. Stop surgery and anesthesia immediately. Hyperventilate the patient with oxygen, and administer dantrolene as quickly as possible. The package insert states that the starting dantrolene dose is 1 milligram per kilogram, which is then titrated up to a maximum cumulative dose of 10 milligrams per kilogram, or until the signs and symptoms of MH are reversed. Some physicians have found a starting dose of 2.5 milligrams per kilogram to be safe and effective. It should be noted that 36 or more vials of dantrolene may be required to reverse the MH crisis for a typical adult patient. Here again, since speed is essential, the procedure followed in some institutions is to mix dantrolene and sterile water in a large bowl rather than in individual vials. Simultaneously, if required for arrhythmias, administer procainamide intravenously 15 milligrams per kilogram. Dantrolene sodium IV should be introduced by infusion into a central vein rather than a peripheral vein to prevent phlebitis. All monitoring lines should be secured and laboratory tests performed to determine arterial blood gas and serum potassium levels. Administer sodium bicarbonate to correct acidosis and check urine for volume and color. Patient cooling is also initiated as quickly as possible. This includes intravenous iced saline, lavage of the stomach and bladder, and ice packs to the axilla and groin. The entire procedure should be carefully monitored in the OR until all signs and symptoms of MH have been reversed and the danger of subsequent episodes has passed.